Since we're all here, I think that we will get started. Thank you, everyone, for joining us today. It is my great pleasure to welcome Dr. Marie-Roseline. Let me introduce myself very briefly and talk about how Marie came to be with us today, and then I'll introduce her and let her take it away. So I am Jessica Cohen. I am a health economist and a faculty member at in the Global Health and Population Department at the Harvard Chan School, which hosts these brown bag seminars. And I am also the co-director of the Harvard Lead Fellowship for Promoting Women in Global Health, which is co-sponsored between my department and between the Harvard Global Health Institute. Marie-Roseline is one of our fellows this year, one of our 4 fellows this year. And the Lead Fellowship is designed to advance leadership skills from individuals from low and middle income countries who will in turn mentor future women leaders in global health. Our Lead Fellows work very closely with Harvard faculty. They engage in personalized executive coaching, take courses, and have the opportunity to build a custom leadership development curriculum to really catalyze their own professional careers and goals. So it is my great pleasure again to introduce one of our 4 fellows this year. She is one of over 2,000 people who applied for the fellowship, who we have the pleasure of welcoming this year. And she's going to lead our seminar today with a talk titled What We Know and What We Don't Know on How to Effectively Engage the Community for Health Security, a topic that she is an expert in. She's been a civil servant with more than 18 years of experience in public health at both the national and global levels. She currently serves as the Senior Emergency Manager at the global level for the WHO. And prior to this, she served as the Emergency Preparedness Lead at the WHO in the Central African Republic. Marie's been working with the WHO since 2015, serving as a team leader of the Health Emergency Program in Mauritania, as well as incident manager of large and complex outbreaks in several countries. Prior to that, Marie worked as an HIV/AIDS medical officer in Haiti and a senior public health expert for the Project Episuth, sorry if I'm not pronouncing that properly, which aimed to strengthen emergency preparedness in 27 countries in the Mediterranean. As scientific manager of the European Union project for chronic diseases and maladies and supportive infrastructures, she helped to advance a resilient approach to NCDs across the continent. And we are so thrilled to have Marie as part of our 2023 cohort. Just a plug that she and the other Lead Fellows will be on campus in the spring semester, and we'll look forward to organizing some exciting and stimulating events with all of them. So the plan for today will be to please hold your questions other than clarifying questions until the final 10-15 minutes of the talk today, and then we'll open it up for comments and questions, and we will conclude today at 2 p.m. And so with that, Marie, I'd like to hand it over to you. Thank you.
Thank you so much, Jess. Good afternoon, good morning, and good evening to everyone, wherever you attend this seminar. So I want to thank the Global Health Institute and Harvard School of Public Health for this excellent opportunity to share my experience in community engagement for health security. So the seminar title today, What We Know and What We Don't Know to Effectively Engage the Community for Health Security, came out after various discussions with my mentors and my peers. So if we are divergent on a specific aspect of community engagement, we all agree that everything begins in the community and everything ends in the community. So the content of my presentation today has 10 points. So we will have a brief introduction, okay, followed by community engagement in health, global health security, and then we will go through a review of what we have in community engagement, as well as the process of putting in place a community engagement program. I have also bring to you an experience I put in place in the Central African Republic. We will also talk about the role and the responsibility of the community in health and security, and we will end with some proposition of way forward. So before we go further, I want to ensure that we have the same understanding of community and community engagement in health. The community could be of different types. We see that we have community of interest. So this community is built by people who are driven by the same interests, like a profession, religion. And secondly, we have the community of place. The community of place is related to the location where you are at the moment. It could be a village, a university, a campus, and we also have a community of identity, like the LGBTQ and others community. And we see that traditionally, a community has been identified as a group of interacting people who live in a shared location. But however, with the internet era, we have seen the development of online communities. They connect people who may never come into contact otherwise. And we see that this kind of communities provide a shared context for people to communicate and share information. These communities encourage a free flow of ideas and information. You see that with the Twitter, that now X, with Instagram and so on. All those kind of community, as we have that we stated, community of interest, community of identity, community of place, and online community, they enable the dialogue between people interested in solving the same or similar problem all over the world. So when we talk about community engagement in health, what does that mean? How can we apply this concept of community in community engagement in health? So we provide you with two definitions from two global health institutions, the World Health Organization and the Center for Disease Prevention and Control. So while the WHO defined the concept as a process of developing relationships to address health issues, the CDC said that is the process of working collaboratively to address issues affecting well-being of the population. As we see, both institutions agreed that community engagement in health is a partnership, is a collaboration with the community. And it is really important to note that without collaboration and partnership, we cannot have engagement from the community in health. Moreover, the same global institutions, WHO and CDC, provide with some description on what is global health security. You see that both institutions also agreed that global health security are the activities both proactive and reactive, that prevent, detect, and respond to mitigate the circulation of threats and protect borders. You see that CDC expresses it very clearly when it said, in today's globalized society, a disease threat anywhere is a disease threat everywhere. So after we have those concepts really clear, how much do we know about community engagement? How much evidence do we have produced so far? We section the title and pull up 4 combinations of terminology in the PubMed during the last 5 years. For the first search about community engagement and effectiveness, we have both terminology into brackets. We found 323 papers. With the same criteria, we pull up community engagement and health security, both terminology again into brackets. We found 44 papers. And lastly, for the terminology community engagement and what we know, in the last 5 years, we find 49. But the what we know, it's not really a term of research. So we try to replace it by research agenda or gap. And we pull up those 2 terminology together to see the community engagement and research agenda with both terminology again into the brackets. We only find 25 papers. Furthermore, many international institutions and non-governmental organizations produce tools to inform the implementation of community engagement in health, in development, in climate change, and so many other areas. But with COVID-19 pandemic, the production of tools has increased and they are more focused now on health and security. To summarize that first part, as you can observe, we don't begin from zero. We don't begin from crash. We process a lot of knowledge on how to engage the community for effective health security. So as we previously see, global health institutions define community engagement as a process. I want to share with you how I apply this process in the Central African Republic. First of all, we divided the process into 4 interrelated steps. The first was to establish a dialogue with the community, to build a relationship that is based on trust and respect. And together with the community, we also identify what COVID-19 interventions are feasible and acceptable based on their culture, on their needs. So we can see that this process is based on the need of the community, not on the need of the health system. The second step was to set the stage. So we use the same community structure that is already exists in the community to set up the coordination of this activity. And thirdly, we gather the facts, we brainstorm, and we listen to the community. We invited the community leaders to co-design the project, to plan, and also we provide them training on performing COVID-19 rapid tests. At this stage, we also implicate all the political commitment that we could have to support that initiative. The last step is the phase of implementation and evaluation. During that phase, we developed tools that can measure the implementation activity. We also set up indicators of success together, and we learn together. While the second step and the third one can be mixed or interchangeable, the first one and the fourth one are not. But however, as you can see, it is a continued process. When you finish to implement the activity, we should come back to the first step to establish again the dialogue, to review and begin also setting the stage, gather the fact, brainstorming, implement, and over and over. So here, we want to share with you the principal roles and responsibility of the community in health security. This is not an exhaustive list, but however, this is the main responsibilities. The community play a crucial role in preventing or anticipating health threats. They can provide information about new risks that they see in the community, or new risks that they identify. To support them in that role, the health system must update seasonal information. The health system must also update the type of risks to which the community is exposed, putting in place community-based surveillance, event-based surveillance, and also surveillance of open source. The second role of the community is early detection. Early detection by reporting the signals, whatever they see in the community that is not a routine, they should report that. The health system in that case must listen to the community, take their concern into consideration, and verify the information with them. After verification, the health system should provide a reporting mechanism to the community. They should send back the information to put a two-way of communication in place. So how do we do that? With focus group, with survey, and also with a community dialogue. After detection and notification, the community also participating in the response to the public health event that has been confirmed after they report the notification. So they participate mainly in the risk communication and also in the infection prevention and control strategies that can put in place during the phase of responding to the public health threat. After the control of the health security event, the community continue to work with the health system in the last phase, that is the recovery phase. During that phase, the health system has to empower the community by training, providing tools, providing information, and set up in a consultative and supportive roles. But at the same time, putting in place mechanisms that involve the community in the reporting. More roles of the community is also the management and infodemic. So infodemic are information that the community is receiving. This information can be bad or good or true, but the fact is that this information is so much that the community cannot process that information. It's becoming too much, and it's coming from all over, from all sources, and the community is not able to select which information to believe or not. So we see with the COVID-19 pandemic that the community engaged in screening the information. So to do that, the health system should ensure that the community have access to trusted information. We see, for example, with the pandemic that the CDC in the webpage provide information every day regarding the epidemiological trends of the epidemic. And other global health institutions do the same, like WHO. At the same stage of infodemic management, it's really important to activate or strengthening the national fact tracking and putting in place some more monitoring capacity at community level that the community can report to the health system the rumors that are ongoing in the community, and the health system can provide the right information. Another role and responsibility of the community is leaving no one behind. This is really important that the same community ensure that everyone in the community is participating in the activities. Everyone in the community is informed about the risk and also the action that are ongoing to mitigate the risk for their well-being. So, saying that, I want to share with you that experience with the Central African Republic that we call CAR. So the Central African Republic is a landlocked country bordered by Chad, as you can see on the map on the left, by Cameroon, Democratic Republic of the Congo, the Republic of the Congo, Sudan, and South Sudan. The country has a protracted humanitarian crisis for the last 3 decades. Life expectancy in the country is 53 years. More than 71% of the population is living in extreme poverty. So every year, the country is dealing with more than 8 outbreaks. Actually, they have monkeypox, yellow fever, COVID-19, measles, and so on. So, with the international health regulation adopted by the countries in 2007, the World Health Organization provides tools to the countries to measure the state of health security preparedness. So the member states submit their auto-evaluation every year in December to mid-January. The Central African Republic has submitted the last one in December 2022, and we can observe that the country has less than 40% of the minimum requirement capacity required to respond effectively to a potential threat. So it was in that context that COVID-19 began in the country in 2020. So it was also in the same context that we have to put in place a strategy of community engagement to mitigate the impact of the COVID-19. So this slide is in French, but I will explain what it is. It is the theory of change that we apply doing this strategy. This theory is based on an equilateral triangle. The vertex 0 of the triangle, the upper one, represents the community and the individuals in the community. The vertex 1 on the left is the community leaders, and the vertex 2 on the right is the healthcare worker. So while the age 0 represents the political commitment, that one on the left, and multi-sectorial activities too, the age 1, is the community health system that we put in place. And finally, the age 2, what is on the right, is empowering and capacity building in the community. The theory said that the health system work together with the community leaders to provide healthcare to the community that has already accepted that leader. It's like that we use the leader like an influencer. And the leader, together with the healthcare workers, they are going together household by household in order to find the most vulnerable people that can be dying by COVID-19. So some result that we obtain after 6 months of implementing that. So we begin with that project in 2020, but the data I will share is August 2021 to February 2022. So this is a 6 month of data. So we see that in 6 months, 1,525,670 households has been visited at least one. Almost 18,000 rapid tests of COVID-19 were performed by the community leaders in the community. With that test, what we foresee is if someone is sick in the community leader perform a COVID rapid test before that person can go to the hospital. If this person is also sick with COVID, in that case, we evaluate if it is a severe COVID or if it is a mild COVID. If it is not severe, so the person is treated at home with all the infection and prevention control measures that we are putting in place in the community. In that project, we also developed the infection prevention control at community level. We developed a guideline that the community translate into local language and distribute those guidelines into the community. Other result that we have, we found out 276 COVID-19 confirmed cases, and we treat them in the community. Only 6 severe cases were transferred on time to hospital. During that intervention, we also found 331 children who were not vaccinated, and we provide them with the vaccination. Actually, the strategy is extended to other endemic diseases like tuberculosis, HIV, malaria, and also maternal health. So some other results that we obtain with the strategy that worth also to be mentioned is that in the context of the Central African Republic, the COVID-19 vaccination has attained 70% of the goal in 2 years. They closed the emergency on 11 September with 140 COVID deaths that were registered during the pandemic. So what are the reasons behind those outcomes? It's because we have an effective epidemic management that was putting in place with the community and by the community. There was also a political engagement from the highest level in the country, and the community received the operational support that they need in order to perform the vaccination. So what was the role of the community in that activity? We developed it with the theory of change that I show you. We developed a package of 13 activities that the community were responsible for putting in place. What is the role of the community in preventing death of COVID-19? So the community, with that theory, and together with the health workers, identify the people who were vulnerable to die with the COVID-19. And those people were followed up every day by the healthcare workers. So it is one of the reasons why the COVID-19 didn't impact it like it was, it was modelized. The COVID-19 only has 114 deaths in the community in Central African Republic. So as we can see, the knowledge we have serves to implement effective community strategy for health and security. But there are also areas where our understanding is limited. For example, optimal engagement and strategies. We see that we need more studies to identify the most effective methods to engage diverse community in health and security. The model I presented to you was implemented in a community with very small diversity. The community was really unified to put the COVID-19 strategy in place. We also lack, understanding on how to sustain the community engagement. How can we put in place long-term sustained engagement for health security? So we observe that the engagement decreases when the risk is decreasing. Is that the engagement is proportional to the risk? So when the perception of risk is very low, the engagement drops down. So we need to work more in collaborative surveillance. We need to put in place and to develop theory of change that includes community engagement and also putting in place 2 ways of communication. Sometimes we found in the community that there is only 1 way of communication. The community communicates to the health system, but the health system doesn't communicate back. There is no retroalimentation system existing. And it is something that we propose in order to have a long-term sustained engagement of the community. We also have limited understanding on how to address the barriers and inequalities in the community. When I was looking, we have very limited understanding of how to effectively address barriers like language barriers, cultural differences, socioeconomic disparities, and mistrust. So what we propose is that more research is needed to develop strategies that promote inclusivity and address inequality in engagement in health and security. Moreover, we have also limited knowledge in integrating technologies into community engagement for health and security. We have very low knowledge of how the technology can impact the community engagement. We don't know the role of technology, mobile application, online platform. How can we obtain the maximum advantage from them? So what do we propose like way forward? We propose that we ensure access and address potential drawback of effective technology integration. And the last one is to measure impact. This measuring impact is really a complex, very complex in the community because we don't have tools that can measure impact. We have indicators that can measure success, rapid success when we put in place the project, but we don't have tools that can measure impact and long-term impact of community engagement in health security. So what do we propose? We propose developing appropriate indicators and framework that assess the outcomes and impact of community engagement on health and security. So we also propose and the way forward. So how can we evaluate community engagement to reveal the unknown? Here we propose 3 things. The first one is to learn with the community. Not learn about the community, but learn with the community. Share experiences and exchange learning with open mind and commitment to learning and listening to the community. Secondly, we have to establish operational, adaptive, and participative community research program. And lastly, establish a strong monitoring and evaluation program. So there is no doubt that community engagement is a powerful tool to achieve health and security. So what we know and what we don't know on how to effectively engage the community for health and security. We can say that there is a balance. There is existing knowledge on community engagement for health security. This is that knowledge that we use so far. This is that knowledge that I also use in the theory of change in the Central African Republic to put in place that program. However, there are still gaps in our understandings. We need to put more research in place, more collaboration, more evaluation efforts that are essential to improve our strategy for sustainable engagement, to address barriers, to measure impact, and ensure effective community engagement in promoting health and security. Thank you so much for your kind attention. So here is the references that I use. So I will share the presentation. And thank you very much. Over to you, Jessica. Thank you.
Great. Thank you so much for that excellent presentation. Sorry we can't be in the room together for you to hear us all clapping. I have a lot of questions that came out of that. I learned a lot in a very short period of time, but I will open it up to the audience first for comments. Please feel free to just unmute and ask or to raise your hand. And if no one's going to interrupt me at first, I'll start, Marie. So for someone like me who found your talk persuasive and intriguing and does research in the community that is intended to be impactful, but wouldn't know where to begin to start incorporating community engagement into my work, what would you recommend? I'm actually going to ask you this in 2 ways. First, to our students about how to get involved in this type of work, and second, to our faculty about and researchers how to incorporate this into our research.
Okay. Should I answer now or we wait for the question?
I think, yeah, why don't you go ahead?
Okay. So thank you so much for the appreciation. And I want to take advantage to say thank you to my mentor. I saw she's online. Thank you for your time. Thank you for joining. So regarding the first question, how to get involved in this kind of research, I think the first thing is to have contact with the country when they are putting in place. I think it could be institution to institution. We found the Ministry of Health that they can provide you with the information, and it can be a relation with the two institutions. It can be also a personal relation if it is you personally who want to conduct that research. In that case, we will need a protocol that should be accepted by the ethical committee in the country. And then the ethical committee will send it to the Ministry of Health or the ministry who is conducting the project. And once the project is validated or accepted in the country, so you have the green light to implement it. But now the implementation phase could be different, because after you have the green light from the political and the legal institution, now we have to work with the community, identify what institution in the community that will support it. If it is an NGO, if it is a public institution. So you have to identify the partner institution that will support you putting in place on that project. However, I can say that in Central African Republic, this project is still ongoing, and they mobilize the funding. As I said, they extended the project to other diseases, and they have a support now from Global Fund, who accepted to finance the project, as they include the TB, malaria, and HIV in the project. So what is the second question?
I was just asking about do you have different recommendations for students who want to get involved with community-based research versus researchers who are already established but not using those methods?
Well, if a student want to be involved, I think there are three different aspects to consider. The first one is the legal part. So the student should come under the umbrella of other institutions. And so the institution should have to establish the contact with the country or the NGO of the institution first before the student can be involved. After we have this legal framework, so now you can decide which student that you can give the project, or depending on the interest of the student. The second one is also the technical knowledge. In those kind of projects, it doesn't need to be a medical doctor, because we see that in the community, it is a really, broader understanding. Okay, not only medical doctors that are going to the community, even though the project is a health project, but the most important is to connect with the community. Yes, and the third part, I would say, is a personal behavior and mindset. As I said, open mindset and behavior, that is really important when we are going to the community. We have to leave behind our grades and becoming a member of the community. We leave behind I can say everything that can work like a wall between you and the community, and embracing the community, working with them, being a member of that community. I can share my experience in the Ebola in DRC. So we went there with very experienced people. We have beating Ebola in West Africa. We have experiences, but we didn't know the context. And I can tell you that the community put us on our knee till we build trust. We put that process I described in place. We begin by, after 1 year of responding, and the outbreak is still ongoing, the international pressure that we have in the outbreak of Ebola, and political pressure. And after 1 year, this outbreak is still ongoing. So this is after that we step back. we leave behind all that we know, and we're sitting down with the community. This is when the response of the outbreak already began. So we build trust because the community before was chasing us. Okay, so first we build trust. We put the response in place together with the community. We plan together with them. We involve them. We are going in the community together with them. This is when we begin. So this is what I would recommend to the student when coming to that kind of work in the community. Thank you, over.
Thank you. Sorry, my dog decided to bark as soon as I unmuted. Sorry, I'm going to look. I do have more questions, but I'm going to look and see if there's anyone in the audience that would like to get in.
I'd love to ask a broad question. Thank you so much, Marie. We really appreciated hearing that. And Jessica had mentioned a little bit some of your previous roles of how you got to this job, which to me just feels overwhelming and insurmountable, the tasks you face, and yet you outlined sort of such a clear path of how to engage at a national and international level. And I would love if you're willing to share just a little bit more of sort of your journey into these roles of how did you gain the skills needed to lead at such a broad level.
Thank you. Should I go ahead, Jessica? Oh, well, yes. Thank you, Behani, for this question. So it is a very, interesting, and I didn't expect some such question will come up. So I was preparing for more technical question. So I would say that my journey began when I left my country and going to Cuba to study medicine. So when I was young, a teenager, I wanted to study medicine, but in my country, medicine is for, rich people that have access to that university. And I began studying engineering. And after 1 year, so I passed on the national exam to obtain the fellowship. And I was the first one for my province. So I went to Cuba and I spent there 6 years studying medicine. After we finished the medicine, I came back to Haiti and I began my specialization in community, in health and family, in family medicine and family and community medicine. So while I was studying, it is when I began working in HIV because I should go to the community. At that moment, the PEPFAR program was beginning in Haiti. And it was an opportunity that we can have a financial project to go to the community. I began working with the community to integrating the health healers, what we call in my country a priest of voodoo, because they were receiving all the patients of HIV, because in Haiti, when you have HIV, you don't go first to medical doctor. You go first to the priest of voodoo because it is something that someone is doing to you. It is not a disease. It is not a real disease. So we assisted that with a very high prevalence of death of HIV in Haiti. And I decided, okay, maybe we should go to work with them because the society, the medical society, the medical community, we such like pushing them away. They are not scientific. We are scientific. We studied. So there is no way that we can work with those people. So when I came, I said, no, we should work with them. Actually, they have our patients. So we should go to them and see how we can. This is how we began putting in place that community engagement for HIV in Haiti. We begin working with the prior healers, and we make them understand that we are co-workers. When you receive the patient, you can treat him, but send it to me too. So we co-treated the HIV patient. This is how the prevalence began decreasing in Haiti. So after that, I went to Spain when I studied epidemiology. And when you are in Spain, I was there like a student with a fellowship. And the earthquake in Haiti occurred in 2010. I was doing the epidemiology program. So I went to Haiti. I started working for 6 months doing the outbreak, and I intervene in epidemiological studies. I conducted the first study in mental health to show that there is a post-traumatic disorder in those Asians that survived the earthquake. So this is how now the WHO in Americas, the PAO, they begin introducing mental health in earthquake in public health. So they use my report to introduce that new area of mental health. So I continue my work in Spain, as Jessica mentioned. I work in so many programs in the National Institute of Public Health in Spain, Carlos III. This institute has so many centers. I work in the National Center of Epidemiology, and then I switched to the National Center of European Project. This is in 2015, and the Ebola outbreak was ongoing in West Africa. And I decided that I would be more useful if I go to Africa to work in Ebola than staying in Spain and doing non-communicable diseases, because at the end of the day, this project was, a non-communicable project, but the tools were already there. It was to promote, and I felt I could be more useful going to Africa. So this is how my journey in Africa began. But before 2015, I went to Africa with the GOAN. GOAN is the Global Alert for Response Network. While I was working in the Institute Carlos III, I went to Africa in 2012 to GOAN, and I put in place in the refugee camp some surveillance system. So I began loving working in Africa because I see that my work is so relevant. My work is so useful. And there is a non-ending project. Everything is useful. Everything is urgent. Everything is great. You see, so I decided that I will begin working in Africa. And since 2015, I began working with I worked with WHO, and I began in Mauritania. But I was going from a lot of countries to support the response of the organization in outbreak. In Angola, I was there to support the yellow fever, so dengue. Well, I was moving a lot all over to support the response of the organization. So actually, I am based after the Ebola in DRC, where I was coordinating. I was redeployed to Central African Republic to coordinate the COVID-19. So my experience in Ebola was used to put in place this strategy in Central African Republic, because in the first 4 months, we didn't receive any support, like a material. So I told them the best tool that we have now is the community, is to work with the community. And we see the result actually. The COVID-19 didn't impact that much as it was pretending that it would be. So this is my journey, more or less. I hope I reply to your question.
Thank you, Marie. I think everyone in the audience can see why you were chosen out of thousands of people to come be part of the fellowship. Fung?
Congratulations. This was a really great presentation. So thank you for this. And you migrated from CAR and DRC, and now you're sitting in Geneva. And what you just presented is a model of process of making sure that our program have maximum impacts, building compliance, cooperation, and resiliency. I'm wondering, do you recommend this, like while you're sitting in headquarters, that this should be best practice for every programs, or as you're alluding to, it's very context and program specific, that this community engagement, like, for example, this would be a really good type of approach for programs that are externally led, like somebody bringing something inside a local community response, or it's a new programs where you're trying to get corporations and compliance. And if you do, what are some of the criteria when you would activate this community engagement process? You know, this obviously will take time and takes a lot of resources. So yeah, get your thought as now you're sitting in headquarters.
Thank you so much for the question. Well, I think now I am in headquarters. So what I'm trying to do is to develop the best practice. We have begin the production, okay, of the best practice, that how we develop it, how was the challenges that we faced, because I didn't present the challenges, but we had a lot of challenges too that we faced. I remember that the first time we began was in April 2020, but we stopped in August 2020 because of the challenges that we faced, some barriers that we face in some community. We have to stop to rethink it and also to begin again. I think we begin more than 4 times. Every time that we begin, we stop, we evaluate, and we begin again. So yes, we are developing that best practice that we can propose to other programs. It is not, I think community engagement is not only a tool for health or security. It's a tool that we can use in any other program, in humanitarian program, we can use it actually. We can also use it in development, in climate change. It is, the basic is to put the community at the heart of what we are doing, is to do it with the community because we are doing it for the community. So I put in my presentation that citation from Gandhi that say, whatever you do, even though you do it for me, if you do it without me, you do it against me. And this is the principle, the basic principle of any community engagement or work. So whatever we are doing for the community, let's do it with the community. I think we are at a moment in the global health where thinking for the community is over, is caduc. We cannot sitting down in our office, a beautiful office, and thinking project that we will just go in the community and implement and come back, you know. So we have to involve the community in all the process. I explained we need to co-design with the community. It is a collaboration, it is a co-creation. And after that, we co-implement and we co-celebrate the success also. So this is what I'm trying to do in that. It is not a book, it is maybe a booklet, but it is to capture that experience and also share the best practice with the world, so everyone can adapt it to the project that they need to put in place in the community. Thank you.
Thank you, Marie. That was your answers to your questions are even more, or as informative as your talk, and inspirational. I guess since we're over time, I'll just end it on that beautiful quote of co-designing, co-implementing, and co-celebrating with the community. And I'll take that with me throughout my career, I hope. So thank you so much for joining us. We can't wait to see you in person in the spring semester. And thank you again.
And thank you to you. Thank you to everyone for attending this seminar. And thank you and bye-bye.